In this meeting edition of the Cardiocast, we're going to talk about the latest research from the American Heart Association meeting in Philadelphia. We've got Catherine Hackett, the MDedge Cardiology editor. But before we get into that with Catherine and all of our reporters, a couple things to talk about. There is a listener survey available in the podcast notes if you want to make the podcast a little better. You can find a link to that in the notes. All of the stories that we talk about here today will be linked in the notes as well. You can read them in their entirety at mdedge.com/cardiology. And we'll be doing year-in-review episodes as we move into December and January. And we hope to hear from you, or I guess hope that you'll join us in 2020. So without further ado, let's bring in the editor of MDedge Cardiology, Catherine Hackett. And Catherine, this is old hat now. We've been doing this podcast kind of a long time. It's over a year.
Yeah, I think this is our fourth.
Fourth time. Wow, unbelievable. So the American Heart Association, the biggest news for me was that there was a pharmaceutical company that had puppies at their booth. And that's where my editorial focus would have been.
That's right. That boomed on social media, I'll tell you that.
Well, they weren't, you have to realize, they weren't like there because they were excess from the drug safety testing program or anything. They were from an animal shelter in Philadelphia.
Oh,
right.
yeah,
Thanks. Mitchel Zoler. So get to introductions. You just heard Mitchel Zoler, and I'm Catherine Hackett, and Bruce Jancin is joining us, as well as Rich Kirkner.
To be here.
Yeah, thank you, Bruce. And Richard Kirkner joining us for the first time. He's our third reporter reporting from the American Heart Association. So I think what we'll do is get to the biggest news first, which you probably have all heard about. It's the ISCHEMIA trial that had interesting results about comparing PCI to medical care in patients with stable coronary artery disease. Bruce, can you talk about that?
I can. This is not only the biggest news to come out of this meeting. This, I think, is the biggest news in years. And this is a epic study. More than 5,100 patients, many countries, NHLBI sponsored. This was a test of two strategies in patients with stable ischemic heart disease and at least moderate, and actually the majority of patients had severe ischemia on non-invasive testing before they were randomized to a conservative strategy of optimal guideline recommended therapy alone, or to going right to the cath lab because they had a lot of ischemia. And we know what happens in the cath lab. And then after that happens, then they would also get optimal medical therapy. And after 3.3 years of follow-up on average, the bottom line was there was no benefit in terms of hard cardiovascular endpoints for the early invasive strategy. And 3/4 of people in the conservatively managed group managed to stay conservatively managed and never had to cross over because of unacceptable angina to PCI. And there was extensive, interesting quality of life analysis involved in the study, and people that were randomized to immediate PCI, the interventionalist approach, did have better quality of life over the 3.3 years, provided they were having angina at baseline at least once a month. But if they weren't, then there was no quality of life advantage over the conservative strategy of medical management alone, because people aren't having symptoms. And so there are more general cardiologists. There's more non-interventionalists in cardiology than there are interventionalists, and this was a bad day for interventionalists. I think that leaders of cardiology are going to start talking once again about workforce needs in interventional cardiology. I asked John Spertus, who was in charge of the quality of life aspect of the study, whether this means that a lot of low-volume interventional cardiologists are going to take up peripheral artery revascularization.
Or TAVRs. Now that just a few months ago, low-risk patients for TAVR got approved by the FDA. So I was thinking that's where... And I remember one of the founders of the TAVR approach, Martin Leon, said that he got into doing TAVRs because he did not think that there was going to be something of a taper down of the more traditional interventional cardiology procedures for coronary artery disease.
Yeah. Well, Dr. Spertus said there will be some weeding out probably of the low volume operators, but that it's not going to be massive because 3/4 of PCIs are done for people with symptoms. And now that primary PCI has diffused out into community hospitals and the expensive and, as it turns out, impractical hub and spokes idea that works in Denmark is pretty much not happening across the U.S.
And what is hub and spokes?
Hub and spokes is you show up at the nearest hospital and then you get transported, airlifted or by ambulance to a place where there are experienced high-volume interventionalists available 24 hours a day. More and more in community hospitals, there is access to such people there. And so there's still going to be a need for a lot of interventional cardiologists, but the reaction really, let's face it, a lot of primary care docs that make the referrals and a lot of general cardiologists that make the referrals for interventional cardiology, they don't really trust interventionalists as a whole. They're a little bit afraid of them, that they are convinced that they're cowboys and cowgirls and they do too much. And ever since the Orbita study a year or two ago, I've heard smart people that don't have a horse in that race, like Bernard Gersh, say, it's an interesting study, Orbita, but it's much ado about nothing because it's got too many problems, too many flaws. So let's just wait and see what ISCHEMIA shows. And ISCHEMIA showed that really no one who isn't having angina at least once a month who's got stable disease needs to go rushing off to the cath lab. And they'll do just as well with medical management.
Now, what I'm wondering, Bruce, is wasn't this shown more than a decade ago in the Courage study? And so why did that not settle the issue, and why might ISCHEMIA settle it when Courage didn't?
Well, in the randomization was the key difference here. There was no opportunity for referral bias because the way Judith Hochman and the other ISCHEMIA organizers set it up was you weren't eligible for the study until you'd already had the non-invasive stress test, so that you knew that you had your angina was due to heart disease, and you didn't have to go into the cath lab to find that out, because as we all know, once you go into the cath lab for the diagnostic angiography, it's very tempting to just go and clear that thing out. But yeah, Courage certainly raised the question, and I think this is the final answer. Yeah.
Now, I have a question. What about adherence? Is there just, with the optimal medical therapy is very good, and that was one of the things that was discussed in this, I think. And do you think that some doctors are just worried that their patients may not adhere to the medical therapy, and maybe they want that little edge of having a stent in there?
I think some doctors are worried about that, and some doctors are feeling like, my time is money, and it's really hard to spend the time to explain the importance of taking these 4 pillars of optimal medical therapy and doing it consistently. And I think that there will be a real people involved with writing the guidelines said that ISCHEMIA will change the guidelines. And John Spertus vowed that he is going to be in charge of developing tools that make it easier to explain these results to patients and their doctors, because it can get a little bit confusing. But this was the result with people on optimal medical therapy as best as they could adhere to it in the real world. And there's been a lot of sniping about this study. I think interventionalists were dismissive, and they maybe were afraid of bad news. And Judith Hochman, who was in charge of the study, got a little riled up in the panel discussion, said, yes, the study was expensive. It cost $100 million. But we've estimated that by not doing PCI and CABG in the people we've identified in the study as not needing it, you would save $500 million every year. And John Spertus had what he later described to me as a spontaneous rant on stage, because there was a little bit of backlash from prominent interventionalists who were saying, well, yeah, but if you look at the results over 4 years, over the first 2 years, the MI rate was 2% higher in the PCI group, and then in the second 2 years, then the curves crossed. In the second 2 years, the rates were 2% lower in the MI group. And John Spertus said, cut it out. Look, that's not how you analyze a study. He used the old, you can't see the forest for the trees, people, metaphor, and you take the results as a whole. There is a lot of interest by people that are not interventionalists and don't have a horse in this race in getting NIH to fund an extension and follow these people longer, because the interventionalist would hope that the curves will diverge late. But as some people pointed out, when you're taking care of patients, you're really looking at like 4 years at a time. So that was a huge study. And they had a pre-specified sub-study in patients with chronic kidney disease. There's been no studies of that population before, and so it was easy with close to 800 patients for that to be the biggest ever. And the bottom line there is those are really sick patients, and it's hard to help them. They did not get the quality of life improvement advantage of PCI, unlike the non-renally impaired patients. So that's going to change the guidelines as well. There's really no point in revascularizing those stable patients.
I think the second most newsworthy story at AHA was DAPA-HF, and there were actually 5 analyses from the main study that was presented at ESC.
Right.
And I think, as you say, the biggest one was the study that analyzed the patients without diabetes who received Dapagliflozin. And can you talk about that? And then we'll talk about the other sub-studies.
Yes. So, as you said, Catherine, at ESC just a few months ago, and then also published in a New England Journal article in September, where the primary results of the DAPA-HF study, which was putting the SGLT2 inhibitor Dapagliflozin, testing it. It was a 4,700 patient study, and 55% of them did not have type 2 diabetes, and the other 45% did. And back at ESC, the big finding, this actually led to spontaneous round of applause by the big audience that was hearing that result, was that the benefit seen in the patients without diabetes was, and I should say these were patients with heart failure with reduced ejection fraction, all of them, HFrRF, and the reduction in cardiovascular death, hospitalizations for heart failure, and urgent visits for heart failure was substantially reduced in the patients that got the DAPA, even if they did not have diabetes. And as I reported, and everybody else decided after that, that immediately made Dapagliflozin a drug that was excellent for heart failure patients, and less, it kind of moved from the diabetology realm to the cardiology and heart failure realm with that one finding. So here, John McMurray, the principal investigator of the study, gave a few more details on Saturday about the finding in the non-diabetic patients, and perhaps the most informative analysis was he divided the population into tertiles. He combined both the diabetic patients and the ones without diabetes, and into tertiles based on their baseline hemoglobin A1C level. And the patients who had totally normal glycosylated hemoglobins of less than 5.6% or 5.6% or less, I should say, had a response rate with the primary endpoint that was essentially the same as the patients who had hemoglobin A1C levels of 6% or higher. So this further data convinced everybody that it was indeed working in patients without diabetes. I should say, people are really very seriously now thinking of Dapagliflozin as what they're calling a foundational drug for patients with HFrRF, which means it would join a RAS inhibitor, which these days the primary drug seen is actually the combination of the neprilysin inhibitor, sacubitril, plus valsartan, the angiotensin receptor blocker. But if not that, only in this study, it was in DAPA-HF, only 11% of the patients were on sacubitril valsartan. The others were on primarily valsartan or other inhibitors of RAS, but you have the RAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, and now you have Dapagliflozin. People are saying wait for another trial, but it's pretty clear that it's at least on a trajectory to be a foundational drug. That's what other people were calling it. So these other reports looked at the efficacy of the Dapagliflozin based on age. The trial actually included a substantial number of patients who were 75 or older. And
That's unusual.
It is. And but despite that, those older patients got the same benefit as patients who were younger, which was important because it showed that issues like frailty and polypharmacy, which is much more prevalent in older patients, did not seem to have any impact on the efficacy of the Dapagliflozin. There was also an analysis that looked at it by a quality of life and symptom measure, the Kansas City Cardiomyopathy Questionnaire, and that looked at both the association of the primary endpoint with baseline scores on the KCCQ, as it's called, and there was no interaction there, so patients who came in with severe symptoms got just as much benefit as patients with mild symptoms. That analysis of the KCCQ findings also showed the extent of the benefit for quality of life that patients received by adding Dapagliflozin to guideline-directed medical therapy, because 58% of the patients who got Dapagliflozin got a 5-point or more improvement on the KCCQ, which is considered clinically meaningful. And what was striking to me was within that group of 58% of the patients, and this includes, by the way, the patients with or without diabetes that was lumped together for this analysis. But 54% of that 58, or 93% of the 58%, or in other words, 54% got a 15-point or more improvement in the KCCQ. And I'm not sure how to describe what that means to a patient, but it's a substantial quality of life improvement. I imagine for these patients it must be life-changing to have a 15-point improvement on that scale. That was added to the benefit picture. And there were other analyses that showed that there was no impact to baseline ejection fraction, ranging from less than 26% to more than 35%. That whole spectrum of patients with HFrRF got benefit. And finally, an analysis looked both at the time it took to get a benefit, and by 4 weeks after the onset of treatment, there was already a 50% reduction in the primary endpoint, placebo patients versus those on Dapagliflozin. And that analysis also showed that it was patients who had had an acute hospitalization for heart failure within the prior 12 months also had, the benefit was regardless of recent heart failure exacerbation, but the ones who had a recent hospitalization had the most benefit. They had a 10% reduction in their absolute rate of the primary endpoint and a 36% relative risk reduction, which compares to a 26% relative risk reduction in the entire cohort.
Well, that
so what do you think? Are we
picture.
going to see a change in the guidelines as a result of this?
Well, as I said before, that people pretty uniformly were saying we have to wait to see another study. This is such a shakeup of the use of drugs for HFrRF, and particularly using a drug that until a few months ago literally was considered to be simply a diabetes drug and not a heart failure drug. I think the most definitive statement was made by Dr. Clyde Jancin from Northwestern, who has led the last 2 revisions of the heart failure guidelines. And I think he's no longer in charge of that because he kept talking about this as thought experiments. So I think he was removing himself from immediately making statements that could be considered official in terms of guidelines. But he was saying that if there is confirmation, the next trial that's expected to come along that addresses this is the EMPEROR-Reduced trial, which is looking at another drug from the same class, SGLT2 inhibitors. This is empagliflozin, which is actually where this whole story started a few years ago, because it was the first observation of an impact on cardiovascular death and heart failure with empagliflozin. Those results are expected out next year, and so probably a year from now will be reported, and if it has similar results, then the answer is yes, this will go into the guidelines as another drug. And one other thing about that people were already starting to talk about how the accumulation now of drugs for treating HFrRF starts to raise questions about what is the appropriate sequence to add these drugs when you initiate treatment for patients. Clearly here, Dapagliflozin was the last agent added on to the others that I was talking about a few minutes ago. But there seems to be a lot of interest among heart failure physicians to now, going forward, do studies that both assess what is the optimal way to start these 4 or so drugs that patients are going to be on. And even because there are so many, I heard Dr. Christopher O'Connor, who edits one of the big heart failure journals, was telling me that he even could see possibly looking into whether one of these drugs could be withdrawn. Clearly it wouldn't be Dapagliflozin because that added on to the others, but within his point, I think, was within the context of using a new drug like Dapa, whether one of the older drugs perhaps is less necessary.
Ooh, which one?
He didn't say. He said it has to be studied.
I bet he didn't, yeah.
We were talking about valsartan in this, in terms of the DAPA-HF, and there was an interesting study, a Canadian study that Rich covered, and I was wondering if you could talk about that. It was about the recall, all the recalls this year because of the contaminant, the carcinogen contaminant found in the generic valsartans. Can you talk about that, Rich?
Yes, both the FDA and Health Canada recalled valsartan in July 2018. That was the first recall. Then there were other recalls after that. Number of other suspected carcinogens were found to be in batches of valsartan. And Cynthia Jakavicius led this study of Ontario health registries. It was a good-sized study, 55,000 plus patients, tracking what happened and 100% of them were on valsartan at the time of the recall. What happened after that? And what happened was that right after the recall, visits to the ED, the emergency department, spiked like 55% in the month after that.
Wow.
And then it evened out after that. But there was another interesting finding that long term, 10% of the people who had been on valsartan were kind of lost. They couldn't determine if they were taking another medication.
If they switched to another
that.
ARB?
Right.
'Cause I
Or
think that
maybe
it might have
just
been.
became disenchanted with their health care, period.
They don't know what happened
Yeah.
to them, which means, 10% sort of fell through the cracks on this, and that led them to basically suggest there has to be a better way of doing these recalls, because there are a lot of people who just don't know. And they tracked it 3 months after, because people get 30, 60, 90-day prescriptions. And after 3 months, that's when it drops off completely.
In Canada, they have a better way of tracking than we do in the United States. Was there any commentary about how we can do it, what that means for us, and how we can track this better ourselves?
And Dr. Jakovicius, although it's a Canadian study, she's from Western University of Health Sciences in California. So she's familiar with both prescribing systems. And I asked her about that. I said, in the U.S., it's very mail order based for these chronic medications, whereas in Canada, they don't rely on mail order as much, from what I understand. And she said, while in the U.S. they do a very good job of notifying the prescribers, they need to do a better job of notifying the pharmacists, because the pharmacists are the people who know what patient got what batch of the medication, and then they can intervene with that patient. But it's essentially in both countries, it sounds like sort of a patchwork system.
And the pharmacist
of
might
notification.
know ways of getting equivalent drugs,
Yes.
or other suppliers, or something like that, where the prescribers would have no clue.
Yeah. Yes. Yeah. They can. They can handle the substitution
Right.
for the drugs.
Yeah, that's
as well.
interesting.
So, but it was a good size study. And I thought 10%. That's in Ontario. That's 5,000 people going around.
And because this was not, as I recall, it was not just one manufacturer. I mean, the first one was a Chinese manufacturer, but we found that just supplier after supplier and batch after batch were found with this. So it became a pretty scary proposition.
Yes.
You might tell yourself that it's, but just forget about valsartan. And then
There were problems with some of the other generic ARBs, weren't there?
Yeah, and it made you wonder about these generic manufacturers in general. It was pretty frightening.
Was there anything mentioned? I mean, is there something about making the angiotensin receptor blockers that makes them vulnerable to having the impurity in the bit?
Well, what was mentioned was that there is concern that this is happening more and more, and
beyond just this class.
Yes.
Yeah.
Yes, and something has to be done in the manufacturing process.
Right.
And it seems that brand name drugs don't have the same. It's not been as much of a problem.
We're talking, yes. I mean, this is generics. And the interesting thing about the recall was at first it was for one suspected carcinogen, and then months later another was added, then another was added.
Yeah.
So it's more than just the nitrosamine that's the problem.
Yeah.
And there hasn't been much information about really what the risk is of taking these. the risk benefit,
No.
yeah, of stopping
they
taking
didn't.
them, yeah.
That would take a long time to figure out, but you just
Yeah.
don't want to do it, really. So is it a matter, do you know, Rich, of them being sloppy in their cleanup techniques of the machinery in the factories? Or?
That's it could be in the inspection process. It could be in the importing process because a lot of these drugs are imported. But obviously it's something that has to be done at the regulatory level to address that.
Was the reaction in the room that this was enough to get that ball rolling, that there was going to be steps taken at a higher level?
I can't say that was the
Yeah.
reaction in the room.
Yeah.
The reaction in the room was more frustration than
Right.
how do we fix this?
That there's carcinogens in these drugs. Yes, I imagine that would be something